Hello everyone and welcome to Clinical Focus. This is DJ.
And J-Man here. Welcome.
I wanna be the very best with people's pain and sores. To diagnose with my blood test, to investigate the cause. Have a listen to what we say, J-Man and DJ. We came here with the goal to broadcast knowledge home.
Radio Man, gotta catch 'em all.
To meet your destiny.
Haematology.
Oh, yes, sirree. That's exactly what I mean.
Radio Man, gotta catch 'em
A heart
all.
so screwed. Oh, please tell me what to do. You teach me and I'll teach you. Radio Man, gotta catch all shows. Gotta catch 'em all. Radio Man.
You're listening to Radio Monash.
Yes, and welcome to Clinical Focus. As we mentioned earlier, it's DJ and
And the J-Man, and we're so glad that you could join us.
so seeing as this is our first show, we thought we'd just do a little introduction. So just to let you know, we are both final years. I'm currently doing geriatrics out in Hayfield in the country. I drove 2.5 hours to be here today.
I'm currently on my holiday rotation. I drove 20 minutes to be here because I don't live that close.
You know how it's like that sounds. And yes, of course, we're both Monash students. And we'll be your co-hosts for the next few weeks. We're going to be covering several haematology topics, starting with,
Today we'll be doing DVT and PE.
and we'll be covering after that thrombophilias.
Yep, and progressing on to anemias, cytopenias, and then finally various hematological malignancies. So that's the general outline for what we plan on doing.
Mm-hmm. Okay, and we plan to bring a different sort of structure to the show. So each week we plan to do, we'll do our opening jingle, we'll introduce the day's topics, and we'll start, doing a little bit of discussion about the various hematological disorders. And throughout the weeks, we might have a guest speaker. We like to do a section on med jokes. Today we're doing, our guest speaker will be Rudolf Virchow from Germany. He's come all the way over here. Is that not right, J-Man?
That is correct, and we're highly looking forward to his presence on the show.
Fantastic. Okay. And we've also got a section called Haematology, which we'll introduce today. Basically, would you like to explain it, J-Man, please?
Well, from the name harmonica, it originates from harmonica combined with mnemonic, and our goal with this regular segment that we're introducing, harmonica, is we plan to bring these two beautiful things together. So we have a number of mnemonics today that we'd like to introduce to you over some harmonica.
Yes, that's beautiful. We'd like to share those with you. And could you also please explain the concept of analamerize? Analamerize.
Another one of our favourites.
Yes.
So that's another regular segment. We will introduce that one to you at the end. It's a bit of a surprise. I don't want to give the ending away, but just to clear you in, analamerize. It's a combination of analogy and summarize.
Okay, beautiful. Thanks, J-Man. That's fantastic. Well,
No worries.
why don't we
Glad
get
to
on
be
with
here.
it?
Yep.
All right. Okay. So, as we said before, we're going to be talking about DVT and PE. So, these two disorders share a lot in common, and they come under the broad term of venous thromboembolism. Now, venous thromboembolism is a term used to describe a spectrum of diseases that begin with Virchow's triad, which we'll discuss later, and the diseases range from DVT to PE and include other things like branch retinal vein thrombosis, central nervous system venous thrombosis, portal vein thrombosis, mesenteric vein thrombosis, hepatic vein thrombosis, renal vein thrombosis, and ovarian/pelvic vein thrombosis. Do you have anything to add there, J-Man?
Yeah, just in regards to that, I was just going to add that, yeah, we're discussing venous thromboembolism, and that's I guess as opposed to arterial, and most importantly, and the two most common presentations that we'll be discussing would be your DVT and your PEs.
Can they hear that?
Thanks for the time
Oh,
update.
okay. Yeah. All right, we know. We'll hurry it up. Stop pushing us. Okay.
They're pushy over here.
Yeah, I know. Art takes time. You know how it is. Okay, so what's the epidemiology of venous thromboembolism, J-Man?
Well, I'm glad that you asked,
All
DJ.
right.
Actually, some sort of stats that I wanted to throw out to you.
Oh.
At the age of 20, the epidemiology of a venous thromboembolic event is 1 in 10,000.
Is that the same as the chance of being struck by lightning? 1 in 10,000.
I do believe it is.
You are joking. So that it's pretty uncommon.
Yeah, I know. I guess there's some statistical sort of art in there, in that being the case. But as we'll discuss later on with sort of risk factors, age and increasing age is a risk factor, and so by the age of 50, your probability of having a venous thrombosis is 1 in 1,000. Which
Okay.
I guess is much less than being struck by lightning.
Okay. I've also got another stat here. It said that approximately 2/3 of cases of venous thromboembolism are DVTs and 1/3 are PEs. And that doesn't leave much room for the rest of them, but 5 to 10% are supposed to be 5 to 10%. There's a 5 to 10% overlap in the symptoms of both, so you might have two things going on there. And interestingly enough, Asians are at reduced risk of PE as compared to Caucasians. Do you know that?
I did read that one.
So
lucky bastards.
So you're a bit luckier than me there, J-Man.
Oh, you're half lucky.
I know. And Black Americans have a 50% chance increased risk of having a PE than whites as well. All right, so let's talk about the etiology of venous thromboembolism. Do you want to start us off?
Yeah, sure. So you did mention before a certain triad, did you not?
Oh, yeah. Oh, the Virchow's triad. Shall we go to our section on harmonica? Shall we give it a try?
Let's please. Let's do that.
All right. Well, let me first. I'll give us a bit of background. Okay. So Virchow's triad is a useful model for understanding the pathophysiology of clots. It consists of vessel wall damage, venous stasis, and hypercoagulability. So with vessel wall damage, the endothelial cell damage promotes thrombus formation, and thrombus formation usually occurs at the venous valves. Venous stasis means that, stasis promotes the formation of thrombi, and it can result in further valvular damage. And of course, if you're hypercoagulable, you're intrinsically predisposed to thrombi. So I'm here. I'm going to share a mnemonic with you now. It's how I like to think about Virchow's triad. It's an easy way of remembering it, and keep going. That was good.
Oh, did I come in too soon? Or
No, I like that.
Would you like some more harmonica?
Yeah, let's give it a bit more harmonica, please. It starts off like this. The mnemonic is Virchow. Capital V, capital I, capital R, and cow. The V stands for vascular trauma, which is the vessel wall damage we see. The I stands for increased coagulability, which is the hypercoagulability I just spoke of. And the R, finally the R stands for reduced blood flow, which is venous stasis. How did you like that, J-Man?
I enjoyed that very much.
And thank you for I didn't know you were that skilled with the harmonica.
Oh, it's a secret talent of mine. I think you have to keep a few things up your sleeve.
Okay. Something you do out of med.
Yeah, exactly
Right.
right.
Or did you
I'll
pick that
jam
up
on the
these
harmonica.
holidays? Is that?
I have had a bit of time to myself
Okay.
since being on holidays.
Yeah. Alright.
Yeah, so that's really interesting that you bring out Werkaustride and it's sort of I guess its relevance in terms of the pathophysiology.
And why don't we expand on that a little, and we'll talk about risk factors for the formation of clots using that model. So things that can cause vessel wall damage and are also risk factors are trauma, previous DVT, surgery, central venous catheterization. If we have a look at venous stasis, things that promote venous stasis are advancing age, immobility, general anesthesia, paralysis, spinal cord injury, myocardial infarction, prior CVA, varicose veins, and advanced COPD. And there are a whole ton of things that lead to hypercoagulable states, including cancer, high estrogen states like obesity, pregnancy, the OCP, HRT, and you also get things like inherited thrombophilias such as factor V Leiden mutations, prothrombin gene mutations, protein C and S deficiencies. But I think I'm spoiling a future topic for us. Am I not?
Yeah, I think we'll probably cover that one in future. But that's a goodie. You're in for a treat.
Okay. Well, what do you think of this one? Should we share another mnemonic with the audience, with our fans?
It could be time for a bit more harmonica.
Can we call them fans? Is that?
I'm sure after listening for about 5 minutes, they'd be fans by now.
Okay. All right.
Started off as listeners, now fans.
Okay.
All
right. So we've got another mnemonic for you. So this mnemonic is his leg might fall off. It's a mnemonic for acquired risk factors for DVT and PE. And now the first letter of each word stands for a risk factor, but the first word, his, it stands for 3 words. So let me begin. History of DVT or PE, immobility, surgery, leg varicose veins. So up to his leg. Might is malignancy, fall is fracture or trauma, and off is estrogen, including pregnancy, the OCP, and HRT. Things like that.
I like it. It's very neat. It's a neat little package, isn't it?
Yeah. You know, I actually have 2 of those.
Packages?
Oh, got 1 package, but I've got 2 mnemonics.
Oh, do you?
Yeah.
Did I cut you off?
Do
you have more to give?
I do.
Okay.
There's a lot
Sorry.
of DJ to go around.
I think the harmonica was coming back.
All right. Beautiful. So our next mnemonic is Alaska, spelt with a C. This is very Middle Eastern. Can you?
Do you not like the flavour?
It's all right. Nothing against Middle Eastern music. So Alaska, spelt with a C, is a mnemonic for the inherited risk factors for DVT and PE. The A stands for an antithrombin 3 deficiency. The L for Leiden, factor V Leiden deficiency. The next A for activated protein C deficiency. The S for S protein deficiency. And the C is C protein deficiency this time. And the final A is, oh, that's calming, is antiphospholipid syndrome. Alaska.
Nice. Nice. Good one. I like that one even better. Those would be available to check out if you were to venture on down to the Facebook page dedicated to clinical focus.
Okay.
And wouldn't that be handy?
Oh, it would be. It would be. So what's that website again, J-Man?
Clinical focus. www.facebook.com/clinical focus.
Very good.
Spelt as you would expect.
Okay.
There's no tricks here. We're pretty upstanding guys.
We're pretty transparent. We like to do everything that way. All right. So let's move on a little bit. Shall we start talking about the different phenomena, the different entities of DVT and PE?
Yeah, certainly.
All right. Would you like to start us off? Would you how about can you tell me what a DVT is, please, J-Man?
Well, DVT,
Just
first,
pretend.
We'll start with the word.
I'm sure we have some first-year listeners here. Just
Deep vein thrombosis.
Oh, yes.
Yep. And usually this refers to DVTs in the lower limbs.
Okay.
It can very rarely occur in the upper limbs. But for the purposes of today, I think we'll keep that as an aside. So in sort of the the deep is
What does that refer to?
as opposed to superficial.
Uh-huh.
So in the deep veins of the legs, this is where a thrombus will form, and we've previously just talked about the various risk factors and things that might precipitate a thrombus, and that having formed is usually the precursor for a PE or pulmonary embolus, which is where. So DJ, I thought you're a bit of an expert on the difference between an embolus and a thrombus, aren't you? Isn't that what you did your PhD in?
That's right up my alley. It is, in fact, previous biomedical scientist. All right. So a thrombus is another term, the medical term for a blood clot, whereas an embolus is any sort of blockage in the vessel system. Usually it refers to something that has broken off from a clot, but you can have things like fat emboli, air emboli, fluid emboli. Does that help you there, Jamie?
Yeah. Well, that just cleared things up.
Yeah.
For me, and that was great. So as we were talking about DVTs and PEs, how do they usually present? Is that
All right. Can I just stop you there, J-Man?
all right? Please do.
Show's going well, but I'd like to get someone else on the show.
Oh yeah.
Well, do you think?
When are we gonna have a caller in?
Oh,
Wasn't that right?
yeah. I was thinking, can we get Ben in the show?
Yeah.
He's just sitting there. He's not doing anything. Ben, have you been introduced yet? Where is he?
I imagine you guys would
lost him.
all be familiar with Ben, the lovable, charming, boyish voice from the previous clinical focused episodes.
Oh, yeah.
Certainly,
Are you online?
Certainly, I doubt that you would be a stranger to Ben.
Houston, we have a problem. Ben!
All
right, guys, I'm here.
Oh, here he is.
Terrific.
Oh, fabulous. All right, Ben. Do you have any questions for us so far?
Welcome, Ben.
Oh, what would you like me to ask you?
Okay. Ask me what the signs and symptoms of DVT are.
Okay, do tell us, DJ, what are the signs and symptoms of DVT?
Oh, well, first, I don't like to do didactic teaching. Let's. Do you have any idea, Ben? Can you give us just give us a starter?
Maybe we might see some bruising.
Okay. Yeah. So, yeah, I think you definitely see some sort of calf swelling. Yeah, you've heard of that, haven't you?
Yeah, absolutely.
And do you reckon you'd get any pain at all?
Yeah, you might get some tingling pain.
Yeah. Okay, that's good. You might let's talk about this actually. A good sort of set of criteria to diagnose a DVT is the Wells criteria
That's
for
interesting.
DVT.
Yeah.
So why don't we talk about it like that? So we'll start off talking about the Wells criteria.
Yeah, do tell us. What is that?
It's basically, thank you, Ben. It's basically a set of symptoms that each have a point if they're present. Okay. So maximum score is 1, 2, 3, 4, 5, 6, 7, 8, 9. Hang on, I got it right. 1, 2,
Yeah, count it again.
5,
See if you got it.
9.
Yeah, great.
Maximum score is 9. And minimum score is -2 because there are 10 items on the list and one of them is worth -2 points. The rest are +1. So the first criteria on the Wells criteria is calf swelling, okay, which we've just mentioned. If active cancer is present, then that's also a point. and that's cancer that's been treated within the last 6 months, or palliative, someone who's being palliated. If you have varicose veins, non-varicose veins on the other side, and if you have a previous DVT, if you've had one of those, or if your entire leg is swollen, if you've got pitting edema that's greater on the symptomatic leg, or you've had recent major surgery, or you've been recently bedridden, you've recently been immobilized, you've got tenderness along the deep venous system, and those are all worth, those 9 things are all worth 1 point. If there's an alternative diagnosis, this is the last criterion, that's more likely than DVT, you subtract 2 points from your total score. So a score of 2 or more, which is quite easy to get, puts you in the category of high chance of DVT. A score of less than 2 puts you in the category of a low chance of DVT.
Terrific. Well, it's a great little tool that I guess clinicians can use to determine someone's probability, as you said, and I guess it's a good little summary of a number of risk factors, some pertinent ones like surgery, and some clinical features which all sort of tie together to give you a pre-test probability. So this is a tool that you use before you launch into any actual investigations, which we'll come to later. And actually, it is a tool that can guide how you use your investigations as well.
I feel like that was a bit confusing though, Ben. Did you burst a blood vessel there? How's your brain going?
Oh, pretty good. You
Pretty good?
You grabbed me at a bad time, you know.
Oh, okay. All right. Well, if we were to summarise, should we just pick the 3 most important symptoms there? Because I feel like the Wells criteria is, I mean, makes me a bit fuzzy.
We've sort of talked about the risk factors and some of the clinical features. I guess if you just wanted to use the Wells criteria, a lot of hospitals have a form dedicated to it, so it's something that you'd probably just pull out.
Yeah, but in terms of the 3 most prominent signs, I'd say were calf swelling, localized pain.
I'd concur.
Yeah, you concur. And probably swelling of the leg, the entire leg.
Yeah.
Yeah?
Yeah, I'd say so.
Yeah. Okay.
I'll quickly just I wanted to talk a bit about clinical examination. So I mean, we've talked about some of the features. So if you were to examine, the calf swelling would be one of the first things that you'd be looking for, and importantly, what has a good sort of what is regarded as a good clinical sign, because there's a number of things out there that that I'll get to and I'll talk about that don't necessarily have a lot of value. So calf swelling and particular asymmetrical calf swelling. So let's say if you have one calf that's 2 centimeters sort of more swollen than the other, that's quite a strong predictive sign in your examination. And the other thing that you'd want to do, I guess you'd approach it sort of systematically with your look.
I would
look and feel. Is you'd want to feel for the warmth.
Yes, that's correct.
Because didn't you mention that's how it could present, isn't it? As a bit of a warm calf. and tenderness is something that you can elicit by gently squeezing the calf. Something that listeners at home might have come across is something called Homan sign.
Or in your car. I don't know.
Or
we broadcast over in people's cars? Could they be listening to us at the moment, Ben? Yeah.
Well, drive safe, guys.
That's a positive.
Guys in your cars, drive safe.
Yep.
All
right.
Don't get too excited by our radio show. So I was just going to say that a sign, like an eponymous sign, Homan sign, which is spelled Homan. Homan sign is something some people might have heard of, and it's where you quite vigorously just bend their foot and dorsiflex at the ankle, and that's sort of a famous sign, eponymous sign that would be associated with DVT.
How do you spell that? Did they just misspell human? Or?
Yeah,
What is that?
quite possibly, or misspelled Homer.
Oh.
And but that's a famous sign, but generally considered of limited prognostic value, and theoretically sort of dangerous in vigorously dorsiflexing the ankle. There's a chance that you could actually make the situation worse and flick off a bit of that loose thrombus, a bit of friable thrombus.
Okay. All right. J-Man, at what stage did you want to get Rudolph on the show?
Oh, that was right. We got to get a caller. We've left him on hold. It's a bit rude. He's called in from Germany. We've left him on hold, but he's I think he's got some patent money because he actually he patented a certain triad. So we'll get him on the line.
Okay. Hang on. How are we going to do that?
Hello,
Oh, hello. Is that Rudolph?
Rudolph here.
Rudolph.
Rudolph here.
Nice to meet you. My name's DJ.
You left me on hold for so long.
I thought you were from Germany, Rudolph.
I was snacking on some sauerkraut.
You sound Asian.
It's getting stale.
At least you've got you've got a decreased risk of PE. That's in your favour, I guess.
I discovered that one actually. Part of my research.
Oh, very good.
So
very-
what do you got me on the show for?
So we just wanted to discuss DVT and PE. We're talking about it with the fans. Could you please tell us? So you are in fact the one who invented the triad. Did you know?
That is correct.
The Virchow's triad.
Virchow.
Yeah, Virchow's triad. And just to give boys and girls a bit of a background.
I'm German.
Rudolph here. He was born in 1820. 1821. 20, I think. No, 1821. You were born-
I'll correct you there.
When was your
Born
birthday? 1821, was it not?
in the 1800th century.
Yes. Okay.
I was born,
Okay.
and I lived for a while. And,
And
one of
he was cryogenically frozen at the age of 81 when he died in 1902.
it's somewhat of a medical miracle that I could be here today.
Yeah, I know.
But what's greater than that is probably the triad that I discovered.
Okay.
Yeah.
Fantastic. Well,
Anyway, I'm not here to glow.
discussed that,
I just wanted to say hi.
Sorry to keep you on hold for so long. Do you have any input about the investigation of DVT and PE, Virchow? Mr. Virchow.
Oh well,
Sir Professor Virchow.
things have changed since I was knocking about in the 1800s.
Okay.
I believe these days you have blood tests.
Okay.
Blood tests.
Yep. All right. Yeah. So let us start by talking about DVT then. I guess as we have been. I don't know if you've heard, but in the past century, we've had the development of the Wells criteria. Rudolph, Mr. Virchow. And if you have a score of 2 or more, you're deemed highly likely to have a DVT, and you warrant further investigation by imaging. However, if you have a score of less than 2, you're deemed unlikely to have a DVT, and a D dimer is indicated to exclude a venous thromboembolism. Does that make sense?
Oh yeah. I don't know. I was just thinking you can put your name next to anything these days. He didn't discover a triad or anything,
Mr. Well.
Mr. Well. But
Yeah,
please continue.
he probably bought his way into it. So I guess the diagnostic test for DVT here would be an ultrasound of the calves if you suspect the thrombus is in the calves. And so what it is you assess different veins in your lower limbs, such as the popliteal, distal femoral and common femoral, for compressibility. So obviously, if you have something in there, they won't compress like normal veins.
You had a
do.
thrombus
Yes.
due to factors in my triad.
Very good. Very good. Right. So the test actually has a sensitivity and specificity of 95%. So it's very good. It's the probably gold standard for diagnosing DVT. D-dimer actually has a sensitivity of 95%. So it's only useful for excluding the disease. Do you remember You might have to jump on the harmonica there for me.
Oh. Oh.
Mr. Burkow.
Well, actually, I've got to go. I've got to go.
All right.
I'll see you then.
You're going back to your cryogenic tank. Is that right?
Yeah, I'm aging. I'm aging out here in the real world. All right. Toodles. See ya.
All right. Toodles. Back to Germany.
Yeah, that was interesting. Let's get some harmonica on.
Okay. All right. So, boys and girls, we have yet another mnemonic. This time, the mnemonic is snout. High sensitivity, rule out. What this means is, if you have a test with a high sensitivity, it is good at excluding diagnoses. The D-dimer is an example of such a test. That was beautiful.
I like that one. I like snout.
Yeah.
Did you come up with that one?
Yes.
Oh, yes. Well done. Well done.
Actually,
well done,
I can't credit myself for that one. I wish I had. I'd really like to put my name to
it's that good
else.
a mnemonic.
It is. Did you know it's actually got a partner? The partner is Spin. Have you heard of Spin?
I do believe that's it's about specificity, is it not?
Yes, it is. Spin. Specificity. Oh, let me start again. Spin. High specificity. Rule in. If you have a test with a high specificity, it is able. You can rule a diagnosis in if the test is positive. Does that make sense?
That's a good one. We're covering a bit of epidemiology, I guess.
We are. Oh, whatever. It's not epidemiology. Something close by. Okay. Well, let's keep it moving.
Cousins.
How about we keep it moving?
But that's good, and that I did allude to a bit earlier with the Wells criteria. So that was something that determines your pre-test probability, and that's a good term, pre-test probability. And so if you were determined to have a low, to be in that low range, which was DJ.
Less than 2.
Less than 2 in your Wells criteria, it would be sufficient to rule out, because the D-dimer is being a sensitive test is good at ruling out. It would be sufficient to rule out a DVT with a D-dimer and leave it at that. An issue with other investigations that we're going to talk about, namely a CTPA.
Oh, okay. Should we finish talking about DVTs, or would you like to jump over?
Yep. Yeah. Let's
we haven't
keep
gone
going.
through the management and complications of DVTs.
Yep.
Just on the Wells criteria, I actually have a mnemonic for that one too.
Oh,
we won't go into that one, I don't think. It's a bit complicated. It's C3PO or R2D2. And we might just put that one up on Clinical Focus.
It's more of an interest one.
Yeah, it's more of an interest one.
But it's a good one. I do recommend it.
And no one's ever gonna just shoot out bloody Wells criteria. I mean, you'd impress the consultant, but there's no other use for it really.
Oh, I might.
It's not going to be on the exam.
It's all good stuff.
Yeah,
I think.
But can I just say, J-Man over here is he's doing his tunes on a fake harmonica. It's not really real. We will have a real harmonica next week, and we'll be sure to bring that in and try our new skills out. Yeah. Okay.
That is something that we're looking forward to.
All right. Well, we're going to get it off eBay. I'm really looking forward to it. Should be in the mail.
Or should anyone want to sponsor the show? Harmonicas.com.
All right. If anyone wants to sponsor the show, harmonicas are $4. So if you buy 2 of them, that'd be fantastic. They're on eBay. They're the little red ones that are made out of wood, and they've got ladybirds on them.
That's our preference, but we're not picky or anything.
Free postage as well, so it's just $4 flat, $4 each. Okay. All right. So can I just quickly say though, there are a couple of other tests that you might want to consider with DVTs. You could do a baseline INR and APTT. You require the baseline INR. So the tests that I'm going to mention, INR, APTT, UEC, LFTs, FBC, they're kind of like baseline tests. Okay, so they're not diagnostic necessarily.
Yeah.
So you want a baseline INR because you're going to be starting anyone with a DVT on warfarin. You also want to do an APTT if you're considering IV heparin. You do a baseline UEC because low molecular weight heparin or Clexane that is affected by renal function. The dose is affected by renal function. And that's, which one's the bad one for your kidneys? It was Clexane, wasn't it?
That is correct.
Yeah. Okay. So you want to find out if you have pre-existing renal impairment. And you do want to baseline LFTs, but an FBE or a full blood examination might detect abnormalities such as an underlying hematological malignancy, or it gives you a look at your baseline platelet count in case of the complication of HIT to heparin therapy, HIT being heparin-induced thrombocytopenia, which is a rare complication of heparin therapy.
Yep.
Yep.
Yeah, but definitely an important one.
Yeah. Okay. Shall we keep the show moving, J-Man?
Yeah, sure. And I was just going to add that the sort of coagulation studies could be relevant in terms of an underlying thrombophilia that we alluded to earlier.
Yes. Okay, good. All right. Do you have any questions at this stage, Master Benjamin? All right. You're being very quiet there. It's disconcerting. So going on to management. Within management, we have some general rules for anticoagulation, don't we? But I might start off by saying, let me find it. If we divide, if you don't have any underlying risk factors for DVT, you begin by using parenteral anticoagulation therapy, and later on switch to oral anticoagulation therapy.
So your treatment regimes are stratified, aren't they? Depending upon what your sort of risks are.
Yeah, exactly. So I was thinking of perhaps talking about provoked and unprovoked DVTs, as well as DVTs associated with cancer.
Yeah.
Yeah. Okay. All right. We'll just go into those major categories. All right. So you sound pretty keen.
Please do.
All right. So
I'm on the edge of my seat.
all right. We'll listen up, boys and girls, because here we go. So in patients with provoked DVTs, they have a relatively low risk of developing recurrent venous thromboemboli in the next 5 years. Whereas patients with unprovoked DVTs have a 30% chance of developing a recurrent venous thromboembolism in the next 5 years. And so the follow-up therapy for an unprovoked DVT is a lot longer, the follow-up therapy with warfarin, than with a provoked DVT. In the acute setting, your primary treatment of a provoked or unprovoked DVT would be low molecular weight heparin, and you begin them on low-dose warfarin as well. Yeah, you happy with that?
I'm happy.
What sort of low molecular weight heparins can you get, J-Man?
Oh, I do believe there's probably two that are quite commonly used.
Yeah.
Enoxaparin.
Yeah.
And another one, dalteparin.
Yeah. Okay.
And they're your Clexane and your Fragmin.
Okay. Good. And if you weren't, that'd be the first line option. You could substitute the low molecular weight heparin for an unfractionated heparin if there was renal impairment or something. That's a basic management of acute DVTs. For chronic DVTs, provoked or unprovoked, how about you tell us about that, J-Man?
For your chronic DVTs that are, did you say unprovoked or provoked?
Yeah. Oh, both.
Both.
Yeah. It's pretty much the same.
Yeah.
Isn't it?
Yeah. Good one.
So, tell me whether or not you agree with my management.
Just run it past me.
Okay. So, it's just what you do is you begin a patient on low molecular weight heparin, and you've got to have them on that for, I'm going to refer to it as LWMH from hereafter, because I'm sick of saying low molecular weight heparin. You put them on it for 5 days until and start them on low dose warfarin until the INR is within therapeutic range. This is so. Oh, thank you.
Sorry.
What are you doing there?
Sorry, please continue.
What were you trying to do? Were you drum rolling my answer? You start them on low molecular weight heparin because warfarin takes some time to kick in. It takes usually 48 to 72 hours to reach a steady state.
Yeah.
And so you give your patient 5 days of LWMH, and you can then seize that after the INR is within the therapeutic range, and it's been within that range for 2 days. And then you continue on low dose warfarin.
Yeah, and interestingly enough, at the start, when you initiate someone on warfarin, it actually has a pro-coagulant effect. So it sort of favours the formation of blood clots and thrombosis, and that's to do with what warfarin does. Warfarin's a vitamin K antagonist, and so its role is often people say that its role is sort of in the manufacture of a number of factors, but more correctly,
So it's like a factory.
A
factor factory. Would you say?
I would say it's not.
It's not.
I would say.
Is that not what you just said?
I would say more. No, I mean.
All right, you go.
So it's actually involved in sort of a modification of the factors that are already sort of in your bloodstream, and it modifies the factors so they can actually bind and function. Yeah,
okay.
And so these factors are often referred to as the television channel factors, which are.
Should we be playing the harmonica?
Should we?
Yes.
Oh,
we should. It is a mnemonic, is it not? 2, 7, 9, and 10. Warfarin. Hey, you keep playing.
Oh, sorry.
I'm doing my voice. 2, 7, 9, and 10. The blood factors that warfarin inhibits. Factors 2, factor 7, factor 9, and factor 10. You may stop now.
Okay.
Beautiful.
Yeah. So you're exactly right, DJ. So it does. In giving warfarin, these factors don't function, and your INR as a result goes up. But in the sort of initial administration and when you initiate warfarin, it does have that procoagulant effect because it's also involved in protein C and S, which are anticoagulant factors. So and their half-lives are a bit shorter than the other ones. So when they don't work and they start not working sooner because their half-lives are shorter, you do have that initial procoagulant effect, which is managed by what you mentioned.
Yeah, so there's a procoagulant effect for the first 48 hours, isn't there?
Yeah. And that's why it's good to cover them with a low molecular weight heparin.
That makes a lot of sense. Yeah. And I'll just add to that you do continue warfarin therapy after stopping the low LWMH. As a general rule, for provoked DVTs, which I guess are more expected, you'd have someone on 3 months worth of warfarin, and for an unprovoked DVT, you'd have them on 6 months worth of warfarin. However, if there was an ongoing risk factor, a major risk factor, such as cancer, you'd have them on an indefinite low molecular weight heparin or warfarin. Yeah. Actually, just to clarify, cancer is in a category of its own. You continue them on indefinite low molecular weight heparin instead of warfarin. Other major risk factors would be thrombophilias and antiphospholipid antibodies, for which you'd continue on indefinite warfarin, lifelong warfarin. Okay, So
And I guess the other important thing that we can just mention is DVT prophylaxis, which is a really big deal. If in spending some time sort of looking at various med charts, there is an emphasis placed on DVT prophylaxis in patients because it's an important cause of morbidity and mortality in the hospital.
Okay, all right. So what sorts of things could we do for DVT prophylaxis?
That would usually be achieved by your low molecular weight heparins, would it not? For the most part. I mean, I understand there are some exceptions where you might opt for a different choice of drug, but
okay. I'll just chuck a few things out there. I understand we've got about 10 minutes to wrap up. So I think what we'll do is we'll just finish DVT this week, and we'll continue PE next week, and we'll chuck another one in there. First show is always a bit slow. We'll go a bit. We'll be a bit more concise next week. So you could also use calf stockings, compression stockings, either the TED stockings or mechanical ones, which are called graduated compression stockings for DVT prophylaxis. Also, you can use as another sort of management for DVTs, inferior vena cava filters. Have you heard of those, J-Man?
Oh yeah. That's something interesting that you bring up. But they're more reserved for quite extreme cases, aren't they?
Yeah. So they're indicated for cases of progressing thrombus, refractory to therapy, and also people in whom anticoagulation is contraindicated. However, they do increase your long-term risk of recurrent DVT. Yeah. So it's like a double whammy. It's a double-edged sword.
Yeah, it is. It is.
Yeah. All right. How about we quickly go through the complications of DVT? Yeah. And then do you want to wrap it up there? We'll
Let's wrap it up.
What do we have after that? So we've got analamerize.
Analamerize. We'll finish off with analamerize, and we'll leave you with that.
Okay. All right. So shall I quickly just go through a couple of the complications, then we'll do that?
Yeah, please.
All right. So complications of DVT include pulmonary embolus. In fact, it occurs in about 50% of patients with a proximal DVT, pulmonary embolus does. Also acute bleeding due to treatment itself. And there's also something called a post-phlebitic syndrome, or post-thrombotic swelling. And also it's quite likely that the DVTs will reoccur, especially if risk factors aren't modified.
Yeah.
And the 30-day case fatality for DVT is 2%. Yeah. So
interesting.
Yeah. Okay. Well, how about we wrap it up there?
Yeah. Okay.
We'll go to our section called analamerize. Yeah.
Where we plan to summarize and.
So what this involves is wrapping up our session over music. We'll be here to talk about PEs next week, and can we go straight to the closing jingle, please? Please, Benjamin.
And right on the wall for clinical focus.
Yeah. All right. Hang on. Sorry, you'll have to. Benjamin, can you restart it?
I want to be the best with people's pain and sores. Diagnose with my test and investigate the cause.
Lymphoma, leukemia, thrombocytosis, PCBD, 6PD, hemochromatosis, anemia, thalassemia, serocytosis, hemophagocytic lymphohistiocytosis.
Catch 'em, gotta catch 'em all.
Gotta catch all shows. Radio Mon!